This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neurointerventional Surgery, set to be published in 2026. It's titled Transverse Venous Sinus Stenting versus Cerebrospinal Fluid Shunting in Idiopathic Intracranial Hypertension, a multi-institutional and multinational database study.
This is a timely topic, Alara. We've seen the incidence of idiopathic intracranial hypertension, or IIH, climbing steadily. As the paper notes, the global prevalence is anywhere from 0.03 to 7.8 per 100,000 people, but those numbers are significantly higher in our patient demographic of obese women of reproductive age. With obesity rates on the rise, we are seeing more and more medically refractory IIH in our clinics.
Exactly. And for those listeners who are residents or students, we're talking about patients with elevated intracranial pressure without a structural lesion. The pathophysiology centers on disrupted CSF dynamics, either impaired drainage or increased production, and elevated cerebral venous sinus pressure. The big debate highlighted in this paper is whether the venous sinus stenosis we often see is a primary cause or a secondary effect.
Right, and that brings us to our surgical options. Classically, we've relied on CSF diversion, VP or LP shunting, to reduce ICP by altering volume and flow. But as we all know from being on call, shunts come with high complication and failure rates. The authors mentioned that over 50% of patients often require revisions.
Which is why transverse venous sinus, or TVS stenting, has emerged as such a compelling alternative. It targets the venous outflow directly. Smaller studies have suggested lower failure rates, but we've lacked large-scale head-to-head comparative data. This paper aims to fill that gap.
Let's dive into the methodology. This wasn't just a single-center review.
No, it was quite ambitious. The researchers used the TriNext platform, which is a federated research network of over 120 healthcare organizations and 275 million patients. They performed a multinational, multi-institutional, retrospective propensity score matched analysis. They looked at data between June 2020 and June 2025.
That's a massive data pool. How many patients did they eventually identify?
They started with a staggering 134,530 IIH patients. Out of those, 1,318 underwent TVS stenting, and 5,383 underwent CSF shunting. To make the comparison fair, they used propensity score matching to create mutually exclusive subgroups, accounting for various baseline characteristics.
For our residents listening, propensity score matching is crucial here because it helps mitigate the selection bias inherent in retrospective studies, essentially matching patients in the stent group to similar patients in the shunt group. Now, Alara, what was the primary outcome they were hunting for?
The primary outcome was treatment failure. The authors define this very clearly as the need for any subsequent invasive procedure. That could be a repeat TVS stent, a CSF shunt placement or revision, or even an optic nerve sheath fenestration, or ONSF.
And the secondary outcomes?
They looked at residual symptoms at the 1-year mark: headache, visual disturbances, papilledema, dizziness, and pulsatile tinnitus. They also tracked the ongoing use of IIH-related medications, like acetazolamide, topiramate, and furosemide. Finally, they assessed healthcare utilization through unplanned hospital readmissions and emergency department visits.
Okay, let's get to the results. This is where the paper gets very interesting for anyone who has to decide between calling an interventionalist or a general neurosurgeon for a shunt.
The results were quite striking. After propensity score matching, the patients who received TVS stenting had significantly lower odds of treatment failure. Specifically, the failure rate for the stenting group was only 9.6%, compared to a massive 38.6% in the CSF shunting group.
That's an odds ratio of 0.169. In clinical terms, that's a huge difference. A failure rate of nearly 40% for shunts really highlights the revision burden we see in clinical practice. What about the symptoms? Were patients actually feeling better or just avoiding the OR?
They were definitely feeling better. Stenting was associated with significantly lower odds of residual headache, visual disturbances, and papilledema. For instance, the odds of having persistent papilledema were much lower in the stent group.
Now, was there any area where shunting actually performed better?
Interestingly, yes, pulsatile tinnitus. The study found that stenting was associated with higher odds of persistent pulsatile tinnitus, 6.7% in the stent group versus 2.2% in the shunt group, with an odds ratio of 3.183.
That's an important point for patient counseling. While the stent might be more likely to stay patent and avoid a second surgery, the patient might still be dealing with that rhythmic whooshing sound.
Exactly. But beyond that specific symptom, the healthcare utilization data really favored stenting. The TVS stenting group had lower odds of unplanned inpatient readmissions, 23.3% versus 38.9%, and ED visits were also lower, 23% for stents versus 34.9% for shunts.
That's a significant impact on both the patient's quality of life and the healthcare system's resources. If you're a hospital administrator or a resident managing the floor, a 15% reduction in readmissions is huge.
It also mentions medication use. Both treatments were effective in reducing the need for IIH-related medications, like acetazolamide, but the overall trends still lean toward better long-term stability in the stenting cohort.
Let's talk about the implications for our practice. The author suggests that both TVS stenting and CSF shunting address different aspects of IIH pathophysiology. Shunting is a blunt tool. It lowers pressure by removing fluid. Stenting is more physiological in a way, if we believe the venous stenosis is a driver of the pathology.
Right. The study notes that venous sinus stenosis, frequently observed in IIH, contributes to reduced CSF resorption. By stunting that stenosis, we're restoring the natural drainage pathway. The fact that the failure rate is so much lower, 9.6% versus 38.6%, really suggests that addressing the venous pressure might be a more durable solution for many patients.
I want to emphasize that treatment failure definition again for the listeners. It wasn't just the stent clotted. It was the patient needed another procedure. So in the shunt group, those 38.6% were often coming back for revisions, which we know can be a downward spiral of infections and proximal or distal failures.
And the study points out that while ONSF is a targeted approach for visual disturbances in papilledema, it's often used as a fallback. In this study, the need to escalate to ONSF or other procedures was much lower after an initial stent.
Now, as with any database study, we have to look at the limitations. This was a retrospective analysis of the TriNex platform.
Correct. While TriNex is powerful because it uses real-time data from electronic medical records and standardizes it using ICD-10 and CPT codes, it's still dependent on the accuracy of that coding. Also, while propensity matching helps, it can't account for every variable that might influence a surgeon's choice to do a stent over a shunt.
True. For example, some patients might have venous anatomy that isn't amenable to stenting, or they might not have a significant pressure gradient across the stenosis. This study doesn't dive into the manometry data of each individual case, but rather the broad clinical outcomes.
Another point to consider is the pulsatile tinnitus finding. Why do you think that was higher in the stent group, Dr. Aris?
It's a good question. It could be related to the turbulence created by the stent itself, or perhaps the fact that while the stent resolves the pressure, it doesn't always perfectly restore the laminar flow in the same way that reducing overall CSF volume with a shunt might. It's a trade-off we have to discuss with the patient.
To summarize for our listeners, this multi-institutional study of over 6,000 surgically treated IIH patients suggests that TVS stenting is associated with significantly lower failure rates and lower healthcare utilization compared to CSF shunting. It also seems superior in managing headaches, visual symptoms, and papilledema at the 1-year mark.
But don't forget to tell your patients about the tinnitus.
Exactly. And for the residents out there, this study really reinforces the shift we're seeing toward neurointerventional management for IIH. If the patient has the right anatomy, meaning transverse sinus stenosis, the data here strongly support stenting as a first-line surgical option over the traditional shunt.
It's a remarkable shift. When I was a resident, shunts were the only game in town. Now we're seeing data from 2026 showing a nearly 4-fold difference in revision rates.
It definitely changes the conversation in the clinic.
Well, that's all the time we have for today's deep dive. We'd like to thank the authors, Jaruni Intrapiramkul, Ansar Rai, and Dyer Lakani from the Rockefeller Neurosurgery Institute for this substantial contribution to the field.
If you want to read the full paper, you can find it in the Journal of Neurointerventional Surgery, April 2026 issue.
I'm Dr. Aris.
And I'm Dr. Alara.
We'll see you next time on the Neurosurgery Hub podcast. Keep learning and keep operating.